Hi, I'm Tidu Manku, and I'm here to talk to you about the aesthetic rehabilitation of periodontally compromised dentitions, and we'll be using an approach utilizing orthodontic extrusion along with dental implants. So, the periodontitis patient presents us with some interesting dilemmas. We see obviously clinical attachment loss involving pocketing, recession, bone loss, and sometimes this can be quite extensive or more localized, and also can involve an asymmetrical pattern, particularly in the aesthetic zone. Like you can see here, we can see two cases where we have an asymmetrical pattern of bone loss along here, and particularly on the case on the right of the screen. How do we restore these? Certainly when we treat them periodontally, we're going to lose some soft tissue volume, and this then can be somewhat challenging to restore aesthetically. Of course, then the teeth are super mobile. We know that whilst today the literature does tell us that we can restore teeth, we can save teeth that are periodontally involved with treatment. The challenge is not just to maintain the teeth, but it's also to produce an aesthetic outcome, and that can be quite difficult in cases like this sometimes. On the perspective of treating these patients, we know that, of course, you could certainly consider, in this case, or perhaps even in both cases, extraction of all the teeth and to fully edentulate the patient, and then consider an implant-supported prosthesis in both jaws, 1 on 4, 6, 8, 10, whichever approach you prefer and the patient would prefer. But that does generally mean that you're going to need to flatten the bone, reduce bone, place the transition line above the lip line, and you're going to need to have shorter implants, larger prosthesis, and a prosthesis which is going to need to last many, many years, considering the ages of these patients. The patient on the left is 50 and the one on the right is 38. And of course, the patient is then going to have prosthetic gingiva and potential issues with cleaning being more difficult, maintenance being more difficult, and also phonetics being quite a challenge in some of these patients with large one-piece frameworks. We also know that these large one-piece frameworks, if we look at the systematic reviews, certainly there tends to be a higher rate of complications and chipping or fracture or delamination of the veneering materials from these, whether it's acrylic or ceramic. Certainly in the various meta-analyses and systematic reviews that have been published, we see quite a significant incidence of technical problems, about 30% at 5 years, 50% at 10 years, and 70% at 15 years. And certainly in my own private practice, I think this is rather too high and would represent too much of a remake and repair situation. And certainly that is not our experience when we use the approach that we will share in due course. Whether we can place implants in the periodontal patient or not, we know that in the literature now we have a good deal of evidence that suggests that we are indeed able to place implants in these patients, but we should expect to see a higher incidence of complications relating to the biology. And that means more peri-implant mucositis and peri-implantitis incidences and a higher level of annual bone loss. Particularly if we look in the Rasparini study, co-workers, they looked at a comparison between healthy and periodontal patients, non-smokers and smokers. And of course, as you would expect, healthy patients do the best, smokers do the worst, and the periodontal patient with smoking is the very worst. Nevertheless, the survival rate is still acceptably high, somewhere around about 90% or so, but a greater amount of annual bone loss seen in these patients. And of course, we have to explain that to our patients and accept that compromise. We encourage our patients to become meticulous with their hygiene and to quit smoking. Typically, this is described as sort of a problem that we would see: a patient with a history of chronic periodontitis and neglected their mouth. And you can see the problems. We have removed all the upper teeth and restored this with a fixed bridge work in small units, which is our preferred approach. We find this produces the least problems over a long time and can be maintained easily because the patient can clean effectively around each of the implants and the ovate pontics and is able to maintain the tissues in good health. This patient was a heavy smoker, continued to smoke, and you can see at 7 years we see a periodontalitis around this distal implant in the lower right mandible. We had to remove the section of the bridge, remove that implant, and you can see after 10 years with good maintenance, he's doing well. And indeed, we've just carried out a 13-year recall just today, in fact, and the patient is very stable and continues to do well. However, contrast this with the occasional case where we have a patient that falls off the wagon, and I have to admit that this is a treatment that we carried out in the 90s when we thought that implants were the solution to everything. And of course, now we know that that's not the case. Indeed, should I have treated this patient today, I would never have extracted any of the teeth. I would probably have restored only the lower right sextant with a couple of implants, and I would have maintained the rest of the dentition and treated it with the approach which we have seen in the literature to, obviously debride the dentition and carry out some orthodontics and restore the patient with a minimally invasive approach rather than with the approach that was utilized. Nevertheless, we learn our lessons and some valuable lessons at that. And of course, we saw for 5 years stability. The patient then fell off the wagon. He stopped coming back for his recalls. Life, just got too busy. He got very stressed. He started smoking again. And then after, you can see by 2007, we started to lose some tissue. We've had some periimplantitis, and we started to lose bone around this distal implant. And now in 2010, we've lost the implants. And I have to say in 2011 or 12, we removed all the upper implants, and the lower implants were lost already. And now we are redoing the treatment with new graft and new implants, and of course a different kind of prosthetic approach because we've lost a lot of tissue. So this is perhaps my worst nightmare case, and I would say my biggest failure in this respect. But nevertheless, we learn and that we perhaps treat this differently today. So let's go forwards and look at our patients. This is the first patient who's 50 with a chronic periodontitis history and a history of neglect, hasn't been to the dentist for a long while and has not had the appropriate level of maintenance and care. If we look at the teeth, we have the typical pattern of drifting and splaying. The teeth are very mobile. We have grade 3 mobility on the incisors and grade 2 or so on several of the other teeth. Structurally, the teeth are also not very sound. We've had a good deal of restorative treatment, which is now breaking down with infection and breakdown a lot of the teeth. And of course, many of the teeth are no longer maintainable. However, if we were simply to extract these teeth in the current situation, we would expect to see significant amount of shrinkage and bone loss, and certainly the patient was keen not to have a prosthetic gingiva and wanted to try as much as possible to restore tissues, which we could take the approach of extracting the teeth and doing some grafting and augmentation. Of course, this has a higher morbidity, and it's not entirely predictable in terms of the outcome, and requires a fairly significant surgical approach for the patient. And so, can we utilize another approach in these patients? We look at the radiographic picture, and you can see that very little clinical attachment in the bone left on many of the teeth, and clearly things are bad. If we just extract the teeth, however, because the teeth are splayed and forwards, the bone is no longer in the right place. So we would need then to flatten the ridges to place our implants, and this would then mean perhaps biomechanically and phonetically, and finally from a hygiene point of view, that the design of the prosthesis is rather less easy to maintain. Strategies for soft tissue, hard tissue restoration are, first of all, preservation when we can, to try and preserve what we have and not to lose anything, particularly relevant for single tooth implant cases where we're doing immediates. Second strategy, again, very common in single tooth cases where we try and restore and reconstruct the bone and soft tissues, perhaps even in larger cases too. The third strategy, which is commonly found in these extensive or fully edentulous cases, which is to use a prosthetic replacement of the soft and hard tissues with pink gingiva, which is made of ceramic or acrylic composite. And examples of these kind of approaches you can see here, some with a sort of preserving approach, as you can see, some with a reconstructive approach, with some surgery, restorative restoration of bone and soft tissue, and of course prosthetic gingiva in some of these cases. And you can see our preferred approach in our practice is to use probably more implants and have short spans of bridge work. We find this produces a lower incidence of veneer fractures, and all of the cases that you can see here are well in excess of 5, some even 10 years follow-up, and you can see a very stable outcome with little or no chipping or fracture of any of the restorations, which is what we like to see. However, are there alternative approaches for these periodontal patients? And yes, what we want to obviously suggest is an orthodontic regenerative approach that's using the roots to regenerate bone and soft tissue. This has been described in literature as forced eruption. We're going to do it a little bit differently, and let's show you our protocol. Of course, first of all, in every patient with a history of periodontitis, we have to stabilize the patient. We treat the caries of periodontitis. We do any necessary structural and endodontic treatments. And of course, we want to carry out full mouth debridement, maybe with a full mouth disinfection protocol. If it's an aggressive periodontitis, of course, with a systemic antimicrobials, oxacillin and metronidazole typically, and the usual periodontal therapy, which is standard today. Second stage will then be to extrude the compromised and failing teeth. Even if we only have a little bit of clinical attachment, we can gently extrude these teeth so that we bring the bone and soft tissue volume down to provide the appropriate extraction sites for immediate placement of implants, or even delayed if you wish, but we usually do it immediately in those areas. And we can then utilize the protocols today to place the implant palatal, using biomaterial such as anorganic bovine bone mineral in the gap, and connective tissue grafts to optimize the volume of the soft tissue. Of course, in many of these cases, however, the sockets are tiny because the roots, the attachment levels are very little, and you're really placing implants into sound bone with very little need to graft in these cases. But we'll discuss this in greater detail. And we then restore with fixed crowns and bridges using small units or even single units in some cases, trying to optimize the biological design and obviously to optimize the home care and maintenance. So stage one is to stabilize, which will involve full mouth scaling root planing and debridement, antibiotics perhaps. It will also involve any necessary restorative treatment to stabilize the teeth. And you can see we start to clean things up. We get tissues healthy, we don't want any bleeding, and we can start to achieve a better starting point for these patients. Key factors in management of implants in the aesthetic zone. So, of course, always place the implant in the right place to have an adequate, stable volume of bone with proper architecture. You've seen in some of my other lectures, I'm sure, that we talk about these key factors to ensure we have an adequate soft tissue thickness at the time of transmucosal connection, so that we have enough volume of soft tissue to prevent need for bone to remodel to create larger width. And this is something that we very much believe in. We often place our abutments earlier these days and design them appropriately, and we disinfect and clean the components to optimize the chance for soft tissue adherence. We design our transmucosal components with a concave profile in the interior, certainly, and we use biocompatible materials as much as possible, clean surfaces, and we develop and maintain the appropriate soft tissue contours by designing our prosthesis with our provisionals, etc. And this is the same protocol that we're going to use in all our cases. And of course, so we move on now to the second phase of the treatment. Of course, we're carrying out orthodontic treatment now to align the teeth and also to gently extrude and retract the upper anteriors. And this is the idea here, is to bring the bone to a more flat architecture, to bring it down, extrude the what was at a much more apical level to bring the arch into a more uniform position. And you can see that we have had some regain of bone around these teeth as we've treated the periodontitis. And we can see that as the mineralization occurs, a slight improvement. Nevertheless, these teeth are hopelessly mobile, and there's really no chance to maintain these teeth in the appropriate in this dentition. So we are placing some implants, and now we're ready to extract the teeth and place our implants to support our restorations. We preserve the bone as much as possible, we thicken the soft tissues, and we try and do this in an optimal way. In this case, we extracted all the teeth. We're going to place some implants. We're using one implant on the left side and the tooth, which was actually periodontally healthy. There's no probing depth other than 3 millimeters around this tooth and no bone loss. So oddly enough, you have one tooth in the mouth with no disease. And we're using this tooth to retain the bridge along with a one implant on the other side. And the bridge will be relined to sit on the healing abutments of the other implants as a simple approach to allow us to retain the bridge adequately whilst its occlusal support is supported under load on all the implants. And of course, we use a titanium component with a 3 millimeter collar transmucosally, remove the index so that we can place this on the implant and then reline the bridge to sit onto the healing abutments. And you can see we've carried out some soft tissue work, frenectomy, along with some connective tissue grafting. It looks a little bit messy at this stage. Provisional bridge is in. We're allowing things to heal. This is kind of how it looks like. So this implant here is retaining the bridge, the tooth is retaining the bridge, and it's also sitting on the healing abutments, so it's supported under loading across the whole arch. And this works pretty effectively actually in these cases, and simple to do rather than trying to connect all these implants to the bridge in one session. So you can see that, just going back actually, you can see that we've aligned these lower teeth, we've saved them, and we have an improvement in the appearance of these teeth periodontally and also the bone. And now we've also placed implants in the lower arch, which we're going to restore conventionally. And in this case, we are using small units of bridge work and single units, and we've restored the case with zirconia abutments and screw retained restorations where possible, and cement retained restorations on zirconia abutments in the anterior. And this is how it looks. And you can see the restoration in place. The one tooth that we decided just to keep and restore. In the end, I couldn't see any real good reason to remove it, and we kept this tooth, and you can see the restorations, the posterior mandible with single tooth crown screw retained restorations, and the maxilla with two single restorations, 3-unit bridges on the anterior and posterior, which are cemented onto the implants and abutments. So a combination of screw retained and cement retained as necessary according to the position and angulation of the implants. This is how it looks. The patient smile, and you can see that whilst it's not a perfect gingival architecture, of course, we have a significant improvement, and it's very acceptable to the patient. It's not really so important because it's not in the aesthetic zone of the patient, and she doesn't really show the gingiva. But the main issue for me is that she's able to then clean this. This is 4 years, and you can see that we've had some regrowth of some of the tissue in some areas, some improvement in the soft tissue volume, which often happens when we do connective tissue grafting. And you can see that the patient is able to keep this healthy. It's a 4-year follow-up. This is the radiograph of the post-op, and this is now 4 years. And you can see that how big an improvement we've managed to achieve, and we have a stable and ongoing situation which is working rather well. And for the patient, of course, you can see that we've brought this bone level here down to the level of the clinical healthy bone on the second premolar, And if we look at the volume, there's been a significant improvement in vertical augmentation of bone and soft tissue using orthodontic extrusion, and the close-up view at 4 years. Our second case is a 38-year-old female with a somewhat unfortunate history. It used to be a heavy smoker. Both patients were smokers, by the way. They both gave up. But this patient used to be a heavy smoker, had an aggressive periodontitis. This is how she presented to my practice with a periodontal abscess here and some bleeding, spontaneous bleeding and probing, and things very, very bad. Obviously, aesthetically, big holes between the teeth. These teeth were all grade 3 mobility and in really poor condition. You can see this history of the patient was somewhat unfortunate. Unfortunately, she's a patient that suffered from some dental neglect. She was treated by another dentist for drifting of teeth with orthodontics, but they neglected to properly manage her periodontal problems, and after orthodontics, things just went downhill. And you can see within a very short period of time, from 1990 to 2005, the breakdown of her dentition. Certainly, if we'd seen her at this stage, we'd probably have a very different picture, and we would have, I'm sure, been able to save all her teeth. But here we are at 2005, and this is what we have to deal with now. Probing, periodontal charting, as you can see, looks pretty grim, and we are faced with a significant challenge. And how do we manage the patient with this kind of asymmetrical bone loss? If we extract everything, we lose a lot of volume. We are for sure then going to flatten the ridge, place implants, and do prosthesis with pink prosthetic material. And I'm not sure that's necessarily the best approach for a patient with this kind of history, given her age and her desire to try and restore as much as possible her original dentition. But certainly that's an approach we could utilize, but we'll present what we did, and I think it's an interesting approach. Of course, today we're trying to use an interdisciplinary approach in all our treatments, managing the dental, periodontal, functional and aesthetic issues, to optimize this as much as possible. And we systematically plan our cases to go through the control phase, corrective phase, re-evaluating as we're going along, before we rehabilitate the patient with provisionals, and then definitive restorations, and of course having a proper maintenance plan to ensure that we keep these patients going over a period of time. So our first phase of stabilization, once again, in this patient we involved in extracting some of the teeth which were hopeless, keeping a few of the failing teeth now that we're going to try and extrude to bring this soft tissue and bone coronally, and we're using a couple of teeth at the back which we will extract later, because just to utilize these as anchorage to help us with orthodontics as we're going along. We don't feel that these multiple rooted teeth with furcation involvement has a good prognosis. But for the time being, we're going to use a few of these teeth, and you can see the brackets on, lingual appliance on, just try and extrude these. So we now start to extrude these teeth using orthodontics in vertical and of course some lateral movements where in the previous case, and to create new ridges for the implants. As you can see, us extruding very gently and carefully. This is rather more difficult with lingual appliances actually, because of the vector of extrusion has to be carefully controlled to prevent the teeth from moving to buckle. And certainly I would recommend it to be done with the buckle brackets, but unfortunately patients in both these cases wouldn't wear them and wanted to wear lingual appliances. So a little bit more challenging for us to do, but nevertheless, orthodontist Dr. Laura Frost was able to treat these cases and extrude them carefully. And we got to the point where we couldn't extrude the teeth any further with the lingual brackets because of the brackets were now in occlusion with the lower anterior teeth. But you see, as we shorten the teeth and extrude the roots, things are moving along nicely. The important thing is to extrude very, very gently, about 1 millimeter a month. It takes about 3 to 6 months to extrude the teeth, and then we retain for a minimum of 3 months in order to allow for the extruded bone to be fully mineralized and stable. And you can see that we reached a point where we couldn't use the brackets any further, So as a patient when we wear labial brackets, we decided to use something slightly innovative, using some magnets which are available from American dental systems in Germany. We endodontically treated these front teeth, placed magnets in the roots and into the pontics, which we retained a bridge on the canines, and also on healing abutments and posterior implants which have been placed by this time. And you can see us then cutting down the teeth, placing magnets in the roots, and leaving a space to allow these magnets to gently further extrude the tooth, because we want to bring its clinical attachment level more coronal to the level of the canines. And then we're ready to extract the teeth and place our implants. And of course, we've created our adequate bone volume using orthodontic extrusion, which has brought the bone and soft tissue with it in this case. So a gentle extrusion rather than a rapid extrusion, which often extrudes the root without bringing the bone. So there is a different approach. So you can see now as we extrude, we can trim the magnets with a burr, and finally the magnets are more or less completely gone, and you can see now we've brought the soft tissue level coronal to the level on the canines, so it's come down a good several millimeters from where it used to be. And now we're ready to extract the teeth. The roots are obviously pretty short, so pretty small sockets, a lot of basic native bone, and we're just going to fill these areas with some anorganic bone mineral as normal, and thicken the soft tissue when we place our healing abutments. So we place a little bit of xenograft into the socket voids, and then place some connective tissue grafts in around each of the implants. We did the first 3 initially, and later on this one. The provisional is then just placed back, realigned to sit on the healing abutments as such, which we customized to create concavity for more soft tissue volume. And then we can restore the case with our fixed crowns and bridges, going through the usual steps using narrow compression copings, designing our abutments on the model to be narrow and concave, emerging and broadening to the emergence profile of the teeth as it becomes more coronal, maximizing the volume of soft tissue around our implants, of course. And you can see us going through the various steps. Here's the design of the abutments, its concave shape, and we decided to go for zirconia abutments in the anterior, titanium abutments on the posterior, PFM restorations posteriorly, and single unit alumina restorations on the anterior. Probably today we would use Emax, but this is a little while ago. Of course, always place a cord whenever you're cementing onto implant abutments to ensure that cement doesn't travel apically, and protect the transmucosal seal from cement ingress. And this is essential and mandatory for any cemented restoration on implants. Double zero cord, gently packed around each of the abutments, and then the crowns can be cemented. And this is how it looks at this stage, and you can see this kind of unusual sort of negative architecture around the teeth, but you see the restoration now, more or less with final restorations in position. This is how it started out. You can see again the lip line wasn't so much of an issue, but the black holes here were, and you can see that we've now changed the shape of the teeth as necessary, less triangular tooth form. But we've now created a stable and somewhat more symmetrical architecture. Had we just tried to keep placing implants at this stage, of course we would have had massive shrinkage because the bone was way up here somewhere. And if we look at the starting point, remind ourselves where we came from, and we can see where we got to. This is now the 5-year follow-up showing excellent stability and maintenance. We even had a little bit of recession on one of the teeth, but not on the implants. As you can see here, you see a nice stable bone architecture around the implants, and massive gain of volume of bone that we've achieved in the anterior. If we go back, you can see what we started with and where we ended up. So you can see it's a massive improvement and gain of bone, majority of which is the native bone of the patient, which has been brought down through the extrusion of the roots. So this is now The protocol again, stabilizing phase 1, carrying out extrusion of the failing or compromised teeth. Of course, if the teeth were maintainable, we could then even just restore the teeth and keep the teeth. But we felt in these cases that the patient's teeth were not stable enough to maintain, as we were very mobile. In phase 3, we extract and place the implants into the extraction sites, typically in an immediate approach in the aesthetic zone certainly, and then we restore with fixed crowns and bridges, either single units or small bridges, as we discussed, for the reasons that we discussed. The substantial benefits of this approach are a significantly less invasive surgical approach than opening a flap, shaving down the bone, or doing reconstructive procedures with bone grafting for these cases. We have a simpler prosthetic design because we have more or less crown and bridge with single units or small bridges. Biomechanically, we've got large implants, small teeth, rather than small implants and large prosthesis. Significantly facilitate oral hygiene because, of course, the patient is treating them just like teeth. They can floss and brush because they know exactly where the implants are. So the maintenance can be maintained to a very high standard. Phonetics are not an issue because the teeth are where the teeth should be. Biologically, I think we have a biological approach in that we've restored the patient's bone and soft tissues. So rather than having to do any significant aggressive bone grafting techniques or using prosthetic gingiva, and we can see that we have stability certainly up to 5 years now. Both these patients, I would say, are now at 5 and 6 years follow-up, and we have other cases also with similar sort of outcomes in these cases. So the limitations, though, of course, there are always limitations. We need to have some clinical attachment on the teeth in the area of the aesthetic zone so that we can actually extrude, because if we have no attachment, then we can't extrude anything. The teeth must be maintainable throughout the course of the treatment. We must eradicate and control the disease, so periodontal therapy is essential. We must have some anchorage, whether that's some posterior teeth or you need to put some implants in for anchorage. And accept the fact that the interdential pillar will not be perfect. We'll not have a perfect triangular tooth form with a 5-6 millimeter pillar with a high scallop. Of course, it's going to be relatively short and flat, as you would expect around multiple implants. And the patient obviously still has to have some teeth in the affected areas for us to be able to do this. But I think we can see that certainly in this patient here, who was 38 years old at the start of treatment, you can see that we've really created a very acceptable gingival architecture, which has been stable over time. And you can see that even as with many of these connective tissue graft cases, we see a little bit of thickening of improvement of the soft tissue volume. And what's interesting is if you look at the radiograph on the right-hand side here, where my mouse is showing, at 5 years, you see some improvement in the bone around these implants. In fact, if we go back to 2007, when we fitted the prosthesis, you see a rather less mineralized looking bone architecture. It almost looks like a reverse architecture, but you can see a faint outline of something here. And then when we look at it after 2012, 5 years later, you can see definitely some further mineralization here and some improvement of the bone levels around these implants, and a suggestion that we're getting some bone growth rather than remodeling and loss, which is interesting. So this is how we started out. Of course, the idea was to take both these cases through with a somewhat unusual rationale to try and restore these patients. You can find the details of this treatment in a publication from myself and my team co-worker, Dr. Laura Frost, who works in the practice with us in our interdisciplinary team, along with Dr. Nikita Mehta and Daniela Mancuso. And between us, we cover the full spectrum of pretty much all the challenges that we can face. And we can see that we take this patient through, both these cases through to an outcome where we've really produced a very reasonable architecture and increased the volume of bone and soft tissue, which has been maintained over many years. So we have some good follow-up to demonstrate the efficacy of such a treatment. So I thank you for your attention, and appreciate that you coming along and looking at this lecture, and I hope you found that helpful. Please feel free to email me with any questions that you have, and you can find my email in the lecture. Thanks.